Welcome to our All Started podcast in North Iowa. My name is Erick Nganyange. I'm your host. My guest today is Dr. Solomon Ondoma. How you doing, man?
Yeah, good, Eric. Yeah, thanks for having me. Yeah.
Welcome to the show, man.
Great.
As a matter of fact, I might start from the current and going backward.
Sure.
So you are one of the few neurosurgeons in, is it in the North Iowa area or is it just Mason City?
Yeah, in North Central Iowa.
In North Central Iowa.
Yeah.
What is the neurosurgeon? If you have to explain to somebody with the knowledge like myself, like, what do you do?
Yeah, sure. Neurosurgeon is most famously referred to as a brain surgeon. Historically, at the beginning of neurosurgery, what neurosurgeons mostly dealt with were problems of the brain. This was pretty much everything from injuries to the brain, infections in the brain, tumors in the brain, stroke, especially the bleeding strokes in the brain. And this was really at the beginning of neurosurgery. So we were brain surgeons. But with time, neurosurgeon began getting heavily involved in the spine.
Oh.
Yeah, because the spine essentially is all the way from the bottom of your skull to essentially your tailbone, and inside that is the spinal cord and nerve roots. Spinal cord is really part of the central nervous system. And then the nerves come there to power your arms and your legs. So injuries to the spinal cord can be debilitating. Infections to the spinal cord, tumors of the spinal cord. So neurosurgeons had to find their way into the spinal cord through the spine, which is a bony structure. And the other thing, the spine is a mechanical structure. That means that it is subjected to stress and wear and tear as we grow. So with the world population aging the way it is, the most common neurosurgical procedures performed are actually on the spine. So spine is about 70% of the work or 80% of the work of a general neurosurgeon, because you're dealing with people that have broken bones of the spine, people that have wear and tear of the spine, which we call degeneration. And as the spine ages and collapses on itself, it begins pinching the nerves. So you have both back pain and leg pain or arm pain with numbness and tingling and weakness. And
that's always tied to the spine?
That's always tied to the spine.
Oh, wow. Oh, okay.
In one way or another. And these things happen to young athletes. They happen to middle-aged people who are in construction and heavy labor work. And they happen to old people just from age wear and tear. All they take is a very small fall, and then they have a fracture of a bone in their spine. And so that is a lot of work. When you think about it, the chance of having a brain tumor is about 1 in 200,000. The chance of having an aneurysm burst in your brain, is even slightly more rare than that. So the traditional diseases that brain surgeons treated are on average rare to begin with.
Okay.
Yeah, but then injuries to the brain and spine or the degeneration of the spine is a much more common problem to deal with.
Okay.
Yeah, and so the training of a neurosurgeon now is partly heavily weighted to just dealing with the problems of the spine as well as those of the brains. And this is something that people get surprised. The other part of the neurosurgeon is the peripheral nervous system. Once the nerves leave the brain and the spinal cord and they go down to power, whether it's the face or the arms or the legs, they are prone to many problems. They can be caught in between small tunnels between bones, like at your wrist, something we call the carpal tunnel, or at your elbow, the funny bone.
Okay.
We call that the ulnar nerve. So nerves can become trapped there due to overgrowth of soft tissues, ligaments. And so it's part of the work of a neurosurgeon to actually go and make room for those nerves by decompressing them. So peripheral nerve surgery is the other aspect of neurosurgery, which we share with plastic surgeons and orthopedic surgeons as well.
Okay.
But growingly, neurosurgeons now can actually almost fully specialize in just the peripheral nerves through a fellowship training. So that's the breadth of neurosurgery. It's so wide, essentially from top of your head to the sole of your foot.
Yeah, wow. That's news to me. How do we keep the healthy spine?
That is a very good and important question. Part of it is we cannot stop aging.
Yeah.
And the other thing is that the human spine is not designed to stay for a long time in its upright, erect posture. So there's more stress on it, especially the lower part of the back. So that's another thing that we cannot change a lot about. So those two things, aging and also the biomechanics of the spine, being in an upright position rather than being on all fours. The things we can change, though, when you think of the spine, it's just essentially a skeleton. And what holds that skeleton? It's muscles.
Oh, okay.
So just maintaining a good level of exercise and maintaining a good core strength of your muscles, both of the back and also of the abdomen, helps to keep that spine upright.
Okay.
The example we use is the same as a tent. What really holds that tent up are the ropes. Once those ropes start becoming weak, the tent becomes staggering on. So the tent is your spine and the ropes are the muscles that hold the spine.
Oh.
So good core muscle strength from exercise, spending more time up on your feet walking, though ironically, and then a good exercise regimen, things that improve core muscle strength and, sit-ups and push-ups and things like that. But just walking, all the research is showing you just 30 minutes of walking is not just good for your muscles, your core, but good for your heart, good for your mind, good for your everything. I mean, our ancestors never had to think about walking 30 minutes a day. They had to walk. They had to gather fruit and go hunting.
Yeah.
So even if they died early from preventable diseases, they did not really suffer so much about the degeneration of the spine. So that's one thing, exercise. And two, of course, coming with that is you don't want to overload the spine. You don't want to be obese.
Oh, okay.
So you got to watch your weight. Okay, and some people are tall, so they can handle more weight for their body, and not all of us are that tall to handle. So weight is another thing. Then three is, habits like smoking. Mm-hmm. So most people in my clinic get surprised when I tell them that smoking accelerates the degeneration of the spine. Essentially, nicotine damages those tiny blood vessels that supply the nerves, that supply the joints of the spine, and so the joints become weak. And so they put more stress on the nerves that are coming out of the spine. It accelerates the drying out of the spaces between the bones that we call the discs.
Okay.
So that's nicotine. Just avoidance of nicotine does not only prevent you from a multiple array of cancers and heart disease and lung disease, but also helps to preserve your spine. So those are just some of the public health aspects of just good spine health. If you can avoid sitting for more than an hour at a time and stand up in about 45 minutes and go back to sitting position, that's very advantageous.
Okay. So like sit down for an hour, because that was my next question. I sit down for a very long period of time at work. Yeah. So maybe just sit for an hour, get up.
Correct.
Like if you have a stand-up desk, I think is even better. You stand up for 45 minutes and then go back sitting down.
Exactly.
Okay.
When you sit, you load your lower back. All your upper body weight is taken by your lower part of your back. When you stand, you redistribute that weight to your hips and your knees. So you take away some of that. Or even just reclining also takes away some of that weight load on your lower back. So again, just changing those positions and postures is just important.
Oh, man.
Yeah. This is what I tell people as a neurosurgeon. My average operation that I do, takes about 3 hours. Okay. So what am I doing the rest of the time? Is talking to people in clinic, talking to patients at the bedside, and managing people in the ICU. So again, 70% of my time is not spent in the operating room. What I'm trained and what I'm paid for is information.
Okay.
Because prevention is always better than cure.
Yeah.
And even after treating someone, you don't want them to come back with the same problem.
Mm-hmm. That's true.
After they have healed, they gotta go back to the good habits. Because if you get an operation at age 45, in this country today, in the United States, you have another 40 years to live.
Yeah.
So you have a good opportunity to prevent a recurrence of the problem.
Most of us, we never seen how brain looks like. We just seen the picture.
Yes.
You have seen the brain in the real life.
Yes. I see that in my work, and I see.
When was the first time you saw it? Like,
Yeah, so the first time you encounter the brain of a human is in your medical education. Okay, because you have to do what they call anatomic dissection to appreciate what is normal and what is abnormal. So you do this on a cadaver or someone who's passed away.
Oh, so you do that at the real brain?
You do that on a real brain. You do
geez.
this as early as your first and second year in medical school, and essentially you have tools to open up the skull. And study the brain from its coverings to the brain itself, to the nerves that leave the brain and its relationship to the other organs, the eyes and the ears. And,
so you actually have to open up the skull?
You have to open up the skull.
How many people drop out after that?
Well,
because I'll be one of those people.
We have some people that essentially dropped out from within the first year. But it's a highly selected group of people to begin with. The fallout rate is not that high, but it's intimidating because many people come into medical school have not really touched someone who's dead.
Yeah.
They've not encountered. They've either seen at a funeral and looked at someone. But it's another thing when to actually touch someone who's dead. And believe it or not, after the first few weeks, the emotion, not that the emotion goes away, but it's not always, you don't always have the awareness that you're with someone who was once alive and had a family and had a life and had all these things. And from an ethical standpoint, it's important to keep that awareness. But from a scientific standpoint, it's important to be able to step back away from that awareness and learn, and not be afraid, because appreciating normal and is important if you're going to proceed and help people and learn what the abnormal is.
So when accidents happen, people taken to the emergency room, their scars open a little bit. Is that when you guys get called?
We get called for pretty much any injury to the brain for which they see an abnormality on the scan.
Okay.
Especially bleeding. Now, people can have concussions. The concussion essentially is a mild head injury without bleeding on the brain and can actually be very serious if there are multiple combined ones. But typically, I'll get them called the emergency room if someone has an injury for which there is a broken bone of the skull, which we call a skull fracture, that may or may not be associated with a bleeding on the brain. But you don't have to break the bone you don't have to break the skull to have a brain injury. Essentially, most injuries arise because inside the skull is the brain, and there's a fluid that bathes the brain called the spinal fluid. And that fluid helps to absorb shock. It helps take away your awareness that you're actually carrying the brain inside your skull because it's sort of floating in there. And then there are blood vessels.
So the brain is just floating inside?
Essentially, it's floating inside the spinal fluid. And that spinal fluid helps to absorb shock. It also helps to feed the brain and also take away the toxins away from the brain. But essentially, what happens when you have an injury to your brain, and injuries are different. If someone hits you with a baseball bat on your skull, you're more likely to have a skull fracture, and that skull fracture may press on the brain, or a blood vessel might be torn and bleed and cause a big blood clot that pushes on the brain. Or if you fall, you could either break the skull or just the bouncing up and down of the brain against the skull will cause injuries to the brain and cause contusions. Or if you're in a motor vehicle accident and you're rear-ended or you have a head-on collision, that sudden movement back and forth with the brain, which you call acceleration, you're moving and then you suddenly stop. When you suddenly stop, the brain bounces back and forth within the skull.
Ooh.
And so that also causes a head injury. So there's a spectrum on which you can just have what we call a concussion with no bleeding, and on the other end, where you can have such a severe sudden stoppage of movement, a deceleration that you can actually essentially shear or tear important connections within the brain that could either leave you dead on the spot or suffer an injury,
Brain injury.
A brain injury that's on a spectrum of different levels of consciousness, and we have a scoring system for that, where 15 is sort of the best that you should have, and then 3 is the worst that you should have. Essentially, you're not moving, you're not talking, you can't respond to pain, you can't open your eyes. And people can remain in that state for weeks or days or months. So those are the things we'll deal with. And once you're admitted to the hospital, if you have a big blood clot that is pressing on the brain, then we have to go pretty quickly to the emergency room, to the operating room to remove that clot. And sometimes you just have a lot of bruises on the brain, we call contusions, and we just have to watch you in the ICU, because when the brain is injured and cells of the brain start to die, they begin absorbing water and the brain begins to swell. Now, here's a problem. If you have a swelling in your belly, you have a lot of room to swell.
Yeah.
And your muscles and the skin of the belly can distend. When you have a swelling of the brain, it's closed in a box, a skull.
There's no place to go.
There's no place to go. Unless you're a baby who has the soft spots on your skull, so you can expand your head. But if you're an adult, you cannot. So when the brain starts swelling in its cavity, it starts getting pushed out of the skull through any opening that the skull has. And now one of the biggest openings of the skull is at the base of the skull, where the spinal cord continues from the brain. But if you start pushing the brain through there, you cut off blood supply. You cut off blood supply to the stem of the brain, which controls your heartbeat, which controls your breathing. And so essentially someone who seems to have had a moderate injury can actually die if they're not closely watched in the ICU and managed aggressively to prevent that swelling process. And we prevent that swelling process in multiple ways. Just by having the head of bed elevated up helps to drain blood and fluid outside the brain. Sometimes we use medications that remove water from the brain. Sometimes we have to put someone in an induced coma, so that there is a reduced brain metabolism and demand by the brain itself, just to bring the swelling down. Sometimes we have to go and remove the skull on one side, just so that the brain has room now to expand. We call that a decompressive craniectomy.
Wow.
So the multiple things that we can do, and again, that is part of the bulk of our training in neurosurgery, is just to manage brain injuries and spinal cord injuries. We have ways of monitoring pressures in the brain. We can either use a clinical exam, make sure someone is still moving all parts of their body and that pupils are reacting. But when they can no longer do those things because they're in a coma, then we have to find invasive ways of monitoring pressures in the brain. We put in tiny probes inside the brain that can tell us the pressure in the brain. This is a continuous process, and we work as a team. It's a lot of work, and you depend a lot on other people to make that phone call to you at 1 o'clock in the morning and say, hey, this has changed and this is what we need to do.
Oh, so when you're on call, that's the type of thing, you cannot even sleep good.
Yeah.
Oh, my.
You got to have your phone by your bedside, and you got to have your pager by the bedside, and if they can't get to you, they got to have your spouse's phone.
Oh, really?
And if they can't get to you, there's got to be someone backing you up, and that's what call is.
Wow.
But we're trained for this. I mean, pilots are trained for staying up long hours, and people who do security work are trained for being up the entire night to watch. So I think that every profession has its trade. The key is to go through the training and get used and know that when the call comes, you're going to be able to wake up and make that decision, or jump in the car or get out of the room if you're in the hospital and go to the bedside.
How many of you guys covering all this area?
So for North Central Iowa, which is really within almost a 1.5 or 2 hour radius, it's 3 of us.
Wow.
Here in Mason City. In the whole of Iowa presently, there's just about 3 places where there's 24/7 coverage for neurosurgery. And that's the University of Iowa, and then Des Moines, and here in Mason City. So we are very, very privileged. We're sort of spoiled, because you usually need at least 3 neurosurgeons to do 24/7 coverage of neurosurgery for a whole month. Otherwise, if it's 2 of you, then you can maybe cover 2/3 of the call. If you're 1, then a third of the call, and people have to be diverted elsewhere. So presently we are fortunate that way, but it's a difficult situation. Iowa has the lowest per capita of neurosurgeons for any state in the U.S.
Oh, the lowest?
The lowest.
Why is that? Cold?
Well, it's the weather, and a lot of Iowa is rural, so young people want to probably go to bigger cities.
Yeah, true.
And also, we have one training program in the state, and you can't retain all that you train. People have to move out and go to other places, do fellowships, and and life happens. So that's one of the barriers.
Mental disability. Connect that with the neurosurgeon. Is it possible for you guys to detect that when the baby has not been born yet?
That's a difficult question. So there is screening, what we call prenatal screening. Now, that's not really in the purview of neurosurgery per se. It's in pediatrics and neonatology obstetrics. And either you already have a suspicion from a family history of certain disorders, what we call genetic disorders that might involve the brain, that might be associated with cognitive problems. And so the prenatal screening is really important for that. That you can pick out, certain familial disease, genetic disease that run in certain populations of families, that you can screen for them and know, and then you make decisions based on that. So that's one thing. The other thing we can screen for actually when you have that 3D ultrasound during the stages of pregnancy, we can pick up clear abnormalities of the brain. One of the commonest, or one of the easiest to pick out, is an abnormally large head for the gestation age. And that could be because there's an entrapment or an overproduction of spinal fluid, that fluid which bathes the brain.
Yeah.
And so you have a lot of water on the brain, so to say, called hydrocephalus. And so that can be detected early enough in pregnancy, and again, decisions are made. Most of those children, if they don't have other serious problems, when they are born and treated early, can go on to live fairly normal lives. There are other associations of brain disorders with spine disorders. That means that there is an abnormal development of the coverings of the spinal cord or the spinal cord itself. So those children might have both a brain problem and a spinal cord problem, meaning that by the time they are born, they don't have control of their bowels and bladder, of movement of their legs. Now, most recently, really within the past 10 years, we're able to actually perform what they call fetal surgery. And so you're able to go and close those defects of the spine and the spinal cord before the babies are born. And so they have slightly better outcomes in terms of preserving whatever function they have, and also preventing entrapment of fluid on their brain, what we call hydrocephalus. So that's neurosurgery's involvement at that level. Okay. And then, of course, during childbirth, babies who are born prematurely have a slightly increased risk of bleeding within those fluid spaces in their brain. It's called an intraventricular hemorrhage. It's because the lining of the inside cavity of the brain, which we call the ependyma, it's raw and fragile in premature babies, and it's easy for it to bleed. When they bleed in the spinal fluid, then the brain is not good at absorbing that fluid, and so we may need to intervene as neurosurgeons by putting in a small drain in the brains to take that fluid out, either on a temporary basis or a permanent basis. So again, that's sort of what I can conjure up as neurosurgery's involvement, either before the baby is born or after the baby is born, that might have a mitigating factor on brain damage, cognitive delay. But mental health itself, as you know, is a much bigger subject than that.
Yeah. And another thing I hear people say it a lot, but I don't know how true this is, that if your brain lacks oxygen in 5 minutes, you can have a brain issue.
That's true. 5 minutes is actually a long time. So there's a saying that time is brain.
That's a new one. I never heard that.
Even 30 seconds of lack of blood supply to the brain would have killed off millions of neurons or brain cells. And that's what stroke is, essentially.
Oh.
Yeah, so
stroke is the lack of oxygen
stroke
to the
is
brain?
lack. Essentially, you plug an artery that's supplying a portion of the brain, and even for a short period of time, you may have irreversible damage to that specific part of the brain, and then you'll suffer consequences of what that part of the brain controls. If it controls speech or movement on the opposite side of the brain, or vision or seeing, so that can be. However, if there is what we call a global reduction of blood supply to the brain, if the baby during childbirth is trapped momentarily during labor, there can be a global damage to the brain because you have a global delay to the
Yeah, I heard those before.
Exactly.
Okay.
Or if someone is trapped in a situation where they can't breathe for a while, if people try to strangulate themselves, hang themselves, they may not necessarily die at the scene, but they are of course an irreversible damage to most of their brain, and essentially they may lose any chance of ever returning to an independent lifestyle. Or if someone has a seizure that's prolonged, because when you have a seizure, there are two things going on. You have this abnormal electric activity that's sort of frying the brain during that time, but if it's prolonged enough, you're not breathing also during that time. So you're getting a double injury, both from ischemia and also just from the abnormal electric firing in the brain.
Okay.
So that those are ways in which the brain can get a global or universal damage.
Oh wow! Let's stay on a. I'm glad you touched on the seizure, because that's another thing I want to talk to you about. What causes seizure?
So what a seizure is essentially is an abnormal electric activity in the brain.
The brain. Okay.
Yeah, and that will be manifested in different ways. It can be from just a generalized abnormal movement of the body, which we call the fits, the arms and legs. They twitch, they spasm, they twitch.
Yeah.
When they're moving or twitching, that's what we call a clonic activity. When you're sort of stiff, that's a tonic activity. And some people, it can be in what they call partial seizures. They're not generalized. They may either just shake or move one part of the body, or make abnormal sounds, or make abnormal movements of their face or their mouth. So it all depends on where the focus of the seizure is. It may begin as a small seizure, then quickly become a generalized seizure. And other people have what they call absence seizures. They just stare in a blank space for a few seconds, and it's easy to miss, especially in children, and teachers might notice it or parents might notice it. But gradually those things all injure the brain in some way, and then they'll delay cognition, academic performance in school, and all these things. So the spectrum is wide, but essentially that's what a seizure is. An abnormal electric activity may be begin in a small part of the brain, then spread to the whole brain, or just be in a small part of the brain and remain as what they call a complex partial seizure. That means that it's either one side of the body, or involves a specific function of the brain, like speech or hearing, or things like that. Now, that's what it is.
Okay.
So the causes are very numerous. It could come from just intoxication. And the brain has limited ways of interpreting something disturbing it. That's why you can be happy and you cry. That's why you can be sad and cry. It can be a lot of alcohol. It can be certain poisons. It can be, drug related. It can be all these things. You can have a seizure.
Can eventually grow out of it? Seizure, usually once
so if there's an obvious cause, if you withdraw the cause, then they'll not have the seizure. Yeah. Now there's a caveat, is that if you have a certain infection of the brain or an injury to the brain, you remain with a lifelong chance of having permanent seizures compared to other people. Or if you bleed in the brain, whether from an accident or from a bleeding stroke, depending where that is, you might also get a seizure. And then many times we cannot explain why someone had a seizure. You and I have at least a 1% chance during our lifetime of having a seizure for which there's no identifiable cause. Yeah, and so the treatments for the seizures, They're not very many, but the initial one is if there's something that's obviously identifiable, you withdraw it. If it's a drug, if it's a toxin or something, then by an infection you treat. And beyond that, if the seizures continue, then you have to use certain medications that prevent the seizures.
With the technology, it's been big deal in the last 10, 15, 20 years maybe.
Yes.
What do you see the future of neurosurgery?
Well, that's a very interesting question because neurosurgery historically has really moved on with technology. The challenges are many. One used to be diagnosis. We did not have a good way of looking inside the brain. Then the X-ray came, we could at least look at the skull. And if you injected a certain dye within the blood vessels, you could see the blood vessels. Or if you injected air into the fluid cavities, you could be able to tell, depending on how the brain shifted, where the problem was. But now we have very advanced technology that can look at the fine structure of the brain in great detail. And so that was a major leap. And then the technology also of accessing and safely opening the skull and controlling bleeding on the brain and safely navigating your way in the brain. That's sort of the newer frontier is navigation purposes. So right now we can take your scan and then feed it into a computer system and then register that with certain landmarks on your skull. And even before making any incision on your skull, I can precisely localize within a few millimeters where a brain tumor is, where an abnormal blood vessel is, so that then the opening on the skull is tailored to the problem rather than making a big opening and then begin exploring and fishing out where the problem is.
Oh, okay. So now you can just open a specific spot.
Correct.
That where the problem is and maybe remove that tumor.
Correct.
Okay.
Correct. Sort of limit the damage to the brain itself. And even on that spectrum, there are tumors that we call low grade. That means they're not very aggressive. They're still the cells are rapidly dividing, but when you look at the brain, it's difficult to tell what is normal and what's abnormal. So now there are techniques of injecting dyes, within the bloodstream that can be taken up within the brain, and you could use a fluorescent camera on a microscope, and it will clearly show you the difference between normal brain and abnormal tissue or the tumor itself.
Yeah.
So that can guide how you do the surgery. And then, of course, awake surgery is also is an old technique. It's just safer now, and we can sort of sedate you mildly, open the skull, then wake you up. And if the lesion or the tumor is in a very sensitive area of the brain, such as your speech or your motor function or sensory function, we can keep asking you questions, making you move a part of your body while we take the tumor out to make sure that we are staying within the confines of what is safe to do. So that's an old technique, but it's more refined because we have better ways of mapping those parts of the brain. The anesthesia has become better. So it's limitless what we can do. We've not even talked about functional neurosurgery. This is, we can put a tiny probe in the brain and then apply, a high frequency, either of ultrasound or radio frequency, and just burn out that spot of the brain that's causing a seizure.
Yeah.
Yeah, and then the seizure will be cured.
Oh, wow. Yeah. Wow. Born and raised in Uganda. Let's go back a little bit.
Home sweet home.
What part of Uganda are you from?
That's another interesting question because so Uganda is a relatively small country, just west of Kenya and north of Tanzania, south of Sudan, and then just east of the Congo, and then Rwanda is in the southwestern border. So it's a small country. You could literally drive across the country in 12 hours. I was born in Fort Portal, which is sort of due west of the country. My father was serving in the army and was a young army officer at the Fort Portal barracks. It was in 78. And my mother was a young nurse, really still in nursing school. So I'm born there. Then I was raised in Kampala, which is the capital city of the country. My father comes from the northwestern part of the country called Arua, and we're just 8 miles away from the Congo and about 60 miles away from Sudan. And my mother comes from the southwestern part of the country called Mbarara, which is actually where I went to medical school. And so I have that dual lineage of a mother who is from the south and a father who is from the north. And we do take our paternal relations traditionally. So when you ask me where I'm from, you're going to say I'm from Arua. I'm a Lugbara. From Arua.
Okay. So you claim both.
So I claim, and the reason I claim both is that because of social and political factors, I was actually raised by my mother's side.
Okay.
Because my father was a soldier in the Means regime.
Yeah.
And after the 79 Liberation War.
Oh, so he was an Idi Amin's regime?
Army, yeah.
Oh, wow.
He was a cadet trained officer in Ghana, but was also a teacher before he became a soldier. So he helped with adult education within the army, but was also a military officer that managed the barracks. So because of that, and him having to run away to exile.
Oh, did he?
Yeah, he had to leave for exile. After the Liberation War, if you know a bit of the Ugandan history, is that the liberating force was composed of your people, the Tanzanians.
Yep.
Offered by the TPDF.
Yeah, Julius Nyerere was big deal on that.
Exactly. Him and Amin never saw eye to eye.
Yep.
And then there were the Uganda National Liberation Front, which was an amalgamation of different forces that met in Tanzania, organized, came along with the TPDF. So, of course, within the Ugandan section of the army, there were people who had a bone to grind or pick with Idi Amin soldiers, for different reasons. And so him and his commanding officer made a decision not to fight.
Okay.
And they said there's no use to fight and lose people in this town of Fort Portal, so we'll hand over the barracks. And so when the TPDF came, they handed over. So there was no war in Fort Portal, and people didn't really die because of Idi Amin's soldiers. So he ended up in Luzira, which is sort of the maximum prison in Uganda, and he was there for almost 2 years until they.
So after he exiled, he came back.
No, this is before the exile.
Oh, before the exile.
Yeah.
Okay.
It's
So
after him and his friends broke out of prison and escaped.
Wait, hold on.
that they had to find their way into exile. So all this time, of course, I'm with my mother and her siblings. So I'm raised by my maternal side.
Yeah. So hang on before you go to your mom. Hang on. I think this is an interesting story before you jump out of that.
Yeah.
So okay, your father before even exile, he was called among other officers like, hey, coming out here, we're going to try to integrate you guys with this new regime.
Exactly.
But they ended up like,
yeah, because this was Uganda army, remember. This was not just a means army. My father was cadet trained in Ghana.
For Uganda.
Yeah, this Uganda army, they're professional soldiers. Many of them had a good education. Others have been trained in Israel and Sandhurst in England.
Yeah.
So they wanted to utilize them because this is a
new day.
This is a new day. Amin was just an errant leader that had to get rid of. And there were some really bad apples within Amin's army.
So your dad ended up getting locked up for 2 years, then they broke out of the prison?
Yeah, they broke out. It's funny because I knew that somehow he had left prison, but I never asked the detail. So for the first time, actually, not more than a year ago, I sat on my mind. They said, how did you actually get out of maximum prison? So then he told me the story. So he said that, because they were officers, they were allowed to sleep on some mats. Not just, they weren't like mattresses. So they had these little mats. And those mats, of course, had those sisal parts of them. So they began removing the sisal part and making ropes over a long period of time. Yeah. Because you're allowed to bring a mat. So they bound up goat sisal. Of course, they'd find ways of hiding this sisal. So they made ropes. Some of them befriended the guards, or the guards befriended them. They would talk to them and play cards with them and things like that.
Yeah.
And then their spouses, my mom used to visit my dad in jail. So one of the guys, they used to bring them soap and small things to use.
Yeah.
So they were able to duplicate the keys for the jail rooms using the soap.
Soap, yep.
Yeah, they would stamp on it, then they would give the soap back to one of the spouses. So they made copies of the keys. So now they had ropes, they had copies of the keys. And so my dad told me they waited for one of those days when the soldiers have been paid their salaries.
Yep.
And
get drunk.
Drunk a little bit of alcohol. So they were able to, get out of the jails, the cells themselves, and they had ropes which they threw over the long fence, because those fences are really high for the prisons.
So
And,
you don't just watch this
like
stuff in the movie.
It's like a movie.
You know this stuff. That's real life.
Exactly. And I'm like, are you just making this stuff? I was like, no. I mean, first of all, these are well-trained people.
Oh, yeah.
So they were able to get over the fence. And then just outside the Luzira Maximum Prison, there's a railway line. So my dad told me that whole night they walked along the railway line to a town called Lugazi. Lugazi is probably, by drive, by car, it would be about an hour, with no traffic, probably even just about 30 minutes out of Kampala.
Yeah.
So they were able to walk through the night and walk to that town, Lugazi. Now, Lugazi had an advantage because it had a big sugar factory,
Okay.
and a big sugar plantation, and also tea plantation by the Mera family, the Indians, the Madhvani group. And so because of that, they usually required a lot of migrant workers
Okay.
to come and work in the plantations. And many of those migrant workers came from West Nile. So there was already a community of migrant workers within the sugar works and sugar plantations that had come to work. And so several of Idi Amin's officers who were from West Nile just went and integrated themselves among those migrant workers for several months. And those people protected them and kept them undercover. And from there, he found his way back to Arua in my village, stayed undercover, then found his way to South Sudan.
Oh,
Actually
wow.
went up to Juba.
Oh, really?
So he lived somewhere between Juba and the Congo, and eventually actually joined Museveni's army just before the takeover.
Oh,
So
man.
that's the story.
Wow.
But so that goes back to how all that time I was raised by my mother's people.
Okay.
Yeah, so I have a strong maternal heritage, and that's why I have the two names. I have Mugisha and Ondoma. Mugisha is from my mother's side, and Ondoma is from my father's side.
Okay.
And incidentally, I speak my mother's language. I don't speak my father's language. Yes.
How many languages is in Uganda?
Well, I don't know the specific number. I'd say probably about 50 or 52 languages that are
Okay.
spoken. And many of those are transition languages, because between every two major tribal groups, there's an intermediate language, which is sort of a combination of those two. But the average person in Uganda will speak, at least 2 or 3 languages just because of that.
Yeah.
You speak English if you go to school. Even if you don't go to school, you have to learn a bit of English. It's the official language.
Oh, English is official.
It's the official language. You
Okay.
have no national language. And then there's Luganda, which is sort of the business language of Uganda.
Yeah.
Baganda, are prominent people as a tribal group, and they were spread different parts of the country. They were used by the British for indirect rule. So there were Baganda envoys of the British in pretty much most parts of the country, so the east and even parts of the north.
Okay.
So Luganda is fairly widespread, and it's sort of the business language of the country. And then Swahili is also a business language because it's used at the borders between Uganda, Tanzania, Kenya, Tanzania, and other parts of Congo, but also TPDF, because the official language of the army is Swahili.
Okay.
But there are parts of the country that are apprehensive about Swahili being the national language because of that history is in a means regime, because Swahili was the language of the army. When the misbehaving soldiers came to your house, they spoke in Swahili. They said, "Fungua mlango."
So they still resentful about Swahili language.
So people are resentful. They say it's the language of the bandits and the language of the soldiers. And up to today, when someone wants to intimidate you in Uganda, they will speak in Swahili.
Oh, wow. In a way.
Even the president, when he's angry, sometimes he'll just speak in Swahili. then he brings on the militant part of him.
Pumbafu.
Exactly. So that's one reason why maybe as a generations change and we forget that part of the history, maybe we'll have Swahili as a national language.
How many languages do you speak?
Well, I speak fluently, of course, English, Luganda, and my mother's language, Lunyankole. And then I speak a bit of Swahili. I can get by. And then in the southwestern part of the country, if you really speak one language fluently, if you speak Runyankole, then you can sort of get along with about 5 other languages. But also being a doctor is an advantage because you don't have control of whom you're going to see in Uganda.
Yeah.
And you can't always use an interpreter. So most people will speak a bit of English, but there are many situations where you find a patient who cannot communicate at all in English. So it's an advantage to have a way of getting a basic medical history, knowing the basic things. Do you have a fever? Do you have a headache? Do you have diarrhea? Or, things like that. So at least that helps. When you're a physician, you have the opportunity to learn, sort of the medical bits of the other languages. So in all, I can find my way around about 10 to 12 languages in Uganda.
Oh, wow. That's incredible. So you went to medical school in Uganda?
Yes, I did.
Oh, for some reason, I thought you went to medical school in Wisconsin.
No. So I went to medical school in Uganda. I got to medical school after high school.
Okay.
When I went to medical school, there were only 2 medical schools.
In the whole country?
In the whole country. So you had to go to one or the other of those. And so I went to Mbarara University in southwestern Uganda. And after medical school, I worked for a few years and came to the U.S. So I did my residency, though, my neurosurgery training here in the U.S.
Oh, okay. Then you were in Madison, Wisconsin to do your residency.
Yeah, so we got Madison, Wisconsin in 2008. And, how I came to Madison is a whole different story.
Talk to me. We got time.
When I finished medical school, I did a year of internship, which is mandatory in Uganda.
Yeah.
And during that year of internship, you're obviously scouting for places to go and find a job. So traditionally, what people did, you either decided whether you wanted to be a general practitioner all your life or whether you wanted to go back and specialize, which is called a residency or a master's in Uganda. So the tradition was that if you wanted to specialize, you went and at least worked for 2 years in some district hospital somewhere, gained some skills. Because residency in Uganda is called actually a master's in medicine. So you're mastering. So to master something, you have the basics. You should have done something. Now you're coming to master it. But anyways, so I had 2 places that people wanted me to go and work. And around September of 2004, about 3 months before I finished my internship, I see this job advert of a hospital in eastern Uganda that was essentially a pediatric surgical hospital. And I had a friend who had worked there he was 3 years ahead of me in medical school, I think 2 or 3. And so I wrote and said, hey, I've seen this advert and I think it's a good fit for me because I want to be a pediatrician. So I want to come there.
Did?
Yeah.
Okay.
I want to come there for about 2 years, work, and then I'll go do my master's in. And he said, you're fine. So I applied and I went and interviewed for the job. September, I think 2004. And I get there and to my consternation, it's a beautiful hospital. It's an American-founded hospital, which I didn't even know, that was essentially run by Americans. And it is a neurosurgical hospital.
Oh,
essentially, what they do is brain surgery for children.
Okay.
And of course, I'm not taken aback, but I'm like, well, I'm way over my head in here. I mean, I just want to come and do some pediatrics. So I meet the person. I'm interviewed by several people, but the main interview, of course, is the medical director, who is a Harvard-trained pediatric neurosurgeon.
Oh, wow.
Who had come to Uganda to work as a missionary with his 6 children. His name is Ben Warf. He's actually now back at Boston Children's at Harvard. He's a professor there. And so I meet this guy. He's a brain surgeon. I never really met a brain surgeon my entire life. Practically, I'd never seen the brain throughout my training. And so I meet, this professor, Ben Warf, and he's the nicest guy. And full disclosure, I say, hey, I want to be a pediatrician. I don't want to be a surgeon. And he's like, well, if you like the job, take it. And, you'll be a pediatrician with some surgical skills and all these things. And I say, well, I know, neurosurgery is difficult. It takes 10 years to be a neurosurgeon and all this, a long time to train. And he says, it's not as bad, So we talk a little bit. But after the interview, the other people still interviewing, he calls me aside to a room and asks me, do you want the job? And I say, yes. And then they ask me, do you want to look at what your contract would look like?
Oh, wow. Right on spot.
So they show me this contract and it has this, big salary. Not really big by those days, but at least it was at least twice what I was being paid or thrice. Actually, they first asked me what I wanted to be paid.
Oh, really?
And I said, well, I don't know. This is what I'm earning. So anything more than that would be
good.
fine. Yeah. So that said, they're like, actually, we do have a residence for you. We have a house. And do you want to have a look at the house where you'll be staying? And everything is happening so fast.
Yeah.
And I'm like, okay. Then they took me across. I see this 3-bedroom house. It's fully furnished and all these things. And they asked me, we can move all these things out, before you come. And I'm like, well,
just
keep them because I have nothing.
Yeah.
I have my bed and mattress and suitcase. That's all. And so they show me, they say, oh, by the way, do you want to do your medical exam today? So that, you don't have to. I'm like, fine. So I do all the lab work. And this is the same day I went to interview. And I'm like, well, I think this is how Americans do their things. It's kind of weird.
That director really liked you.
Exactly. So I go back to Mbarara and I tell Sisi Wadena, like, hey, I interviewed and I got the job and I signed the contract and I saw the house where we're going to stay and all these things. We're dating, we're not even married. So that was my entry into Cure Hospital, and it turned out to be a really great experience. So after my internship, I went and started working in December 2004. And within 6 months, the senior resident left to go and do his residency at the University of Cape Town in neurosurgery. So it was the two of us. And after a short time, my senior colleague, she decided she didn't want to be a neurosurgeon. She decided to become a neurologist. So within those 6 months or so, I sort of become the most senior surgical resident who barely knows anything. It's like I got in at the deep end of the pool, and soon she leaves, and at some time I'm the only one there. So the long story short, during that time I began asking myself, maybe this is what God wants me to do. I mean, people don't want to come here. Eventually one of my former classmates in med school joined me and started working. And so that's when the seed, I think, gets planted.
Okay. That's when you realize, okay,
I realized, I can do this. And besides, I began doing actual brain surgery. And it wasn't as scary, and I had a very good mentor. He was a very good surgeon, something I never dreamt about doing. And so mentorship is really important, and where you land in your first job and experience can be a big influence. So anyway, Ben Warf had to leave Uganda eventually because his kids were growing. One was in college in the US, and for practical reasons he had to come back. And before he leaves, and I believe this is probably somewhere around 2006 or 7, he invites me and Sisi over to his house. We had gotten married by then, and says, what do you guys think about coming to the US? It's like, it's no guarantee that you will get in the training program, but there's a chance you could get in. And if you don't, you can get in training anywhere. Yeah. So he's
talking about you.
He's talking,
you getting a training program to be a
neurosurgeon. Yeah,
okay.
It's like, you can. It's like you're good enough to be doing many things, but you actually have to go through an official training program and actually get the diploma that says you're a neurosurgeon. And say you'll be good wherever you train from, but try your luck, come to the US. I know a few people I can connect you with, and you can come and work in a lab as a researcher, take your boards and interview. So by coincidence, the chairman of the program at the University of Wisconsin had been my mentor's partner at the University of Kentucky before he took up the chairmanship.
Okay.
The head of pediatric neurosurgery at the University of Wisconsin had visited our hospital in Uganda and spent some time helping with work.
Okay. So this guy from University of Kentucky was your mentor?
Yeah.
From Uganda?
From Kentucky, he came to Uganda.
Oh, he came to Uganda. Okay.
And spent almost 6 years in Uganda, about 6 years in Uganda.
Okay.
Now, one of his former partners in Kentucky had become the chairman of the University of Wisconsin.
Okay.
Yeah. So, and then there was one other professor in Madison, Wisconsin, who used to come and visit our hospital, a pediatric neurosurgeon called Leland Albright. So it was like, it can't be a coincidence that there are 3 people in one place that are my really good friends and are good surgeons and are good people. He wrote an email and said, I have this young guy and, I think he could do well at training in neurosurgery, and, do you have a place in your lab where he can come and work? And that's all it was. The next email I get from Barman's Iskander, professor of neurosurgery in Madison, and the chairman, Bob Dempsey, They're like, okay, Ben Waffas told us about you, and we believe him. And when do you want to come to work? What kind of visa can we get you? Those were the questions. There was no interview. There was no.
Yeah. Oh wow.
So that's how the process begins. And so I actually come as a research associate to the University of Wisconsin, the Department of Neurosurgery. We land here on August the 29th of 2008 with our 2-year-old. Yeah, and that's how we made our transition here. And so I worked in both labs of the chairman, did spinal cord injury research and stroke research on mice and rats. Those were my patients for almost 3 years, and did all kinds of experiments on them. But it gave me very good microsurgical skills because a lot of the models were actually surgical models. You had to perform procedures on these very tiny animals and cause strokes in them or cause spinal cord injuries in them, and then test different drugs and interventions on what could cure stroke or what could cure spinal cord injury, or at least make the outcomes better. So it was a whole new different experience. I'd never been in a basic sciences research lab. I had to learn a lot of things, but it was a good time. So I during those 3 years, I took my board exams, I got my license, and then I officially applied to train in neurosurgery.
Okay, so after the 3 years there, then is that when you came to Mason City?
No. So after the 3 years, this is 2011. This is when the official training begins in neurosurgery.
Okay. Yeah. Okay.
This is a 7-year training program.
Oh my goodness.
Yeah, that's neurosurgery is the longest residency training program. That's where you get to learn all these things about the brain and the spine and the nerves, and then take care of patients in the clinic, in the ICU, in the operating room. Spend a lot of time in the lab doing research, rotate through other specialties like plastic surgery, ENT, trauma surgery, neurology. So it's very intensive training.
Yeah.
7 years, and at the end of those 7 years, which was 2018, is when I applied to come to Mason City. It's another story of its own.
I was about to ask, like, how did you even know about Mason City out of all places?
I never knew anything about Mason City. I don't think I'd come to Dubuque, maybe. That's the nearest I'd been to Iowa. But so towards the end of your residency, usually around, nowadays begins as your 5th year of those 7 years, even your 4th year, you begin thinking about what you want to subspecialize in, because you cannot really be good at everything.
Yeah.
My interest from the outset was pediatric neurosurgery. So as I get towards the end, my 6th year, I apply to different fellowship programs. Now that time, Sisi was also doing her PhD.
Okay.
She had at least 2 years to finish her PhD in nursing. So the conundrum was there was no fellowship training program in Wisconsin for pediatric neurosurgery. The closest was in Chicago. So I would have had to leave her for at least a year with the 3 kids. So the next option was to get a job. Now, in the US, if you're a foreign medical graduate and you do specialist training here, once you graduate, you have 2 options. You either go back to your country for at least 2 years before you can come back and freely apply for a job here without conditions, or you can take a job in an underserved area for your specialty.
Okay.
For at least 3 years, then get on a green card track. So the year that I graduated, there were 10 positions in the United States that were recruiting a neurosurgeon who was foreign trained for medical school. And so they had to process a work visa for you. So you call it J1 trainee, so you come on an H1 visa. So of those places, the closest to the University of Wisconsin, where Assisi was Mason City.
Okay.
Yeah.
Okay, I see.
So we came and interviewed here so that she could be able to go back and forth. You know, at the very worst, if I had to come and start work, I wouldn't be far away from them. But at least I would be working or have a better income to look after family. And so that's how we came to Mason City.
Okay.
Out of pure serendipity, interviewed at 2 other places in Missouri and Arkansas, but by far this was the best. I have great partners here. And you read into the people. Yeah. And it was, so the history here of neurosurgery in Mason City is very stable. Mm-hmm. Essentially, my practice was begun by, Dave Beck, my partner. in 1987. I was in 3rd grade. and he's still there up to now. He's my partner.
Oh, wow.
So it's been a stable program. So the stability is very important because there's a reputation. Because you can't stay that long in a place with a bad reputation.
That's
exactly,
true.
yeah.
That's true.
And then my other partner, Dr. Sandeep Bangu, he's been here now for more than 10 years. And so there was that stability of two people that have been there a long time. And Sandeep, his father, Sandeep is Indian. Sandeep's father was born and raised in Uganda.
Oh, really? Oh, wow. What a coincidence.
Yeah. And not just raised, it was actually in Mbale, the very town where I worked, and went to my high school. So right off the bat, we had a connection there.
Oh, wow.
A really small world. And so, and we joke in surgery that you can go work any place as a surgeon as long as your spouse is happy to be there. So,
and I'm sure Sissy loves Mason City now.
So I told Sissy, you make up your mind. I'll go wherever you want us to go.
Yeah.
And so, she chose Mason City. So that's how we came to Mason City. So everything and we never planned for any of these transitions in life. And I think being open-minded and being willing to take up new challenges and change from what you thought was your dream to be to something else, and mentorship and opportunities, all those things, play a part in that. And so it's sort of been our story. And, even now we don't know what the next 10, 20 years will bring.
Yeah. And that's what makes life beautiful, man. It's like one opportunity to open up. The next thing you know, let's take that.
Yeah.
And it's like next thing is that take you to something else.
Exactly.
Before you know, 10, 15 years in, it's like,
exactly. Yeah.
How did we get here?
Yeah. We look back now and we're like, how did we manage to go through a residency, Sissy do her PhD,
3 kids,
raise kids, and even be crazy enough to have a third one.
Yeah.
When I was in my senior year of residency, and she was, halfway through her PhD, and part of the challenge here for us is, unlike people who are born and raised in the US, we don't have this supportive extended family.
Yeah.
You don't have your siblings or your parents or to help you. And there are times I would be in the operating room and I would get a call from daycare and they were like, your kid is not doing well. We tried to call your wife. We can't reach her. Can you come pick your kid? And I would have to tell my professor that I got to go pick my child. And I'd have to scrub out of the operating room and go to, pick a child from daycare. But they were very understanding. And that's probably a good thing about the American culture is everyone understands the burden of raising children, daycare and all these things. And they know these are realities,
Yeah. You're still going back to Uganda a lot to do some medical work.
Yeah, I do. I do try to go back at least once a year, and I primarily go to the medical school where I trained in southwestern Uganda. And I've done this since I was in residency. Actually, during my residency in my 6th year, we get an elective period of 3 months, and you could spend those 3 months anywhere in the world.
Okay.
So those 3 months, I went back to Uganda. The reason I kept going back was that at my former medical school, there was one neurosurgeon. If you know anything about the geography, is southwestern Uganda will serve everywhere from northern Tanzania to Rwanda to the Congo. I mean, if you have a medical problem, you're going to just cross the border, and if there's one neurosurgeon serving about, that's a big population. I mean, it's gonna be at least 8 million people.
Yeah, it's a lot for one person.
For one person, and so that's where my burden has always been. Now, the good news is that he has 2 partners that have joined him. Actually, we've submitted the curriculum for starting a neurosurgery training program.
Okay.
And we already have 1 candidate. So hopefully, before the end of this year, there will be an official training program there, and I'm part of the faculty there. And so between teaching and doing cases when I go back and taking whatever medical supplies that I can take. Neurosurgery is a very expensive discipline, even here in the US. Yeah. Every bit of equipment we use is very expensive, and they break down and you need to fix them and things like that. So how to pay for that cost is still the biggest challenge. I think that, Uganda has no national health insurance system. It's about to begin. Healthcare is quote unquote free, but what's really free is the consultation and the medical work and maybe some basic medications. But beyond that, the families have to buy everything. So if you come with a brain tumor, we say, we're happy to do the surgery, but this is what you need to buy. Buy all these medications. So that's a big challenge, how to finance for that.
Yeah, that can be a problem.
Yeah, but there's a lot of hope because with technology transfer now, I don't have to physically be in Uganda to give a lecture. In fact, now there is augmented reality where you can practically see what someone is seeing in the operating room. And then you can share opinions and say, oh, maybe this is how you should approach this. And you can be in the US and that person is in Uganda. That's being done right now. Mm-hmm. Image transfers, and we can combine ideas on things like that. And I also learn a lot when I go back to Uganda. One of the ways I learn is how to use minimal equipment to get through a case. Where you have limited resources, you have to be very technically good because the buck stops with you.
Yep. You work with what you got.
When I trained, if you couldn't do a cesarean section in 15 minutes, you weren't good. You had to get through the case really quickly. So some of those things train you to be really good, and I think that those are the opportunities. But also now, what's one of the challenges in the US is training, especially hands-on training, because there's a limited number of patients for certain conditions, and also because of the medical legal aspects. You cannot leave a trainee to do a certain procedure from beginning to end on their own.
Yeah.
So there's a likelihood that your graduating neurosurgeon in America has not independently taken care of a patient during their training. Now that opportunity is available in Uganda or Sub-Saharan Africa. So I think that's a great opportunity because there are only so many things that you can do via augmented reality and simulation. At some point, you have to touch the human body and the tissue. And
you got to touch the brain.
and feel it. and know how it feels and know how to manipulate blood vessels and nerves without injuring them. That's tactile, that's learned. It's very difficult to simulate that part. So I think that's another opportunity that's there. And so with time, there will be collaborations where I'll be going with residents back home to Uganda from the US and vice versa, and bringing residents from Uganda to the US. To come and get an experience. So that's sort of, that's such a short time. It's not that far away.
Yeah.
The next 2 to 3 years, hopefully.
Okay. Man, thanks for the teaching, man.
No, it's a tour de force. I mean,
this was a classroom for me. My goodness.
No, for me, it's like teaching. The person who teaches learns the most. Because we talk about these things in tidbits and small nuggets, but not as a story.
Yeah, and that's what I wanted to sit down and talk to you, kind of like you can narrate the whole story. Well, Doc, thank you very much, man.
No, it's a pleasure. Thanks for having me.
Thanks for your
it's
time.
It's exciting. This is sort of officially my first a podcast. I've done a few radio and TV interviews before in my life.
There we go. You got a first podcast.
This is unique.
Yeah. Well, thanks, Doc.
No, thanks for having me. And, let's do this again.
All
Thank you very much.
No problem.